to laugh until I can't breathe. Midnight moonlight dancing, never get enough sleep. Oh, the whole night through. And we could count the distance.
Good evening, everyone. Thank you for joining us tonight for our 7th and final session in our Chrysallis Wellbeing Series. Tonight's topic is borderline personality disorder and deliberate self-harm. So my name is Charles Broadfoot and I'm one of the professional development officers with Hunter New England Central Coast PHN. I would firstly like to acknowledge the First Peoples and traditional custodians of all the lands in which we are meeting on tonight, pay my respects to elders past, present and emerging, and also welcome any and all of our Aboriginal friends and colleagues who might be joining us online too. So tonight's session is being recorded and the recording and slides will become available from tomorrow on our PHN website. So to access this recording and previous recordings, you just head to our homepage, thephn.com.au, and click on the Education tab. So we will be using Slido for questions and the session evaluation tonight. So you'll see Slido is integrated and it's on the right-hand side of your screen. So you'll see the polls and the Q&A tab. Alternatively, you can go to slido.com, S-L-I-D-O, and enter the event code CWS7. So that stands for Chrysallis Wellbeing Session and then the number 7. Alternatively, a third option, you'll see a QR code pop up on your screen. So if you scan that, that will also take you to Slido for your questions. So please type your questions throughout the main presentation. We have allocated time after this at the end of the session for a panel discussion. So it's now my pleasure to introduce tonight's speakers. So we have Dr. Nick Bendit. Nick is a staff specialist psychiatrist working at the Centre for Psychotherapy in Newcastle. He treats patients with BPD using the conversational model and DBT, as well as supervising mental health clinicians in the management of patients with BPD. We're also joined by Dr. Mark D'Souza. Mark is a GP working at Brunker Road General Practice, as well as holding appointments as a VMO in palliative care and psychiatry. So Mark works in the Psychiatric Emergency Centre, where he assesses acute presentations and also runs a general psychiatric outpatient clinic at the Lake Macquarie Community Mental Health Team. And thirdly, we are joined by Sandra Fitzgerald. Sandra is a clinical editor with Hunter New England Health Pathways. Thanks again for joining us, everyone, and I'll hand over to you to kick us off, Mark.
Yeah, thanks, Charles. Hi, everyone. So thanks very much for joining us. Could I have the first slide, Todd? Great. So Nick and I both work in Hunter New England Mental Health. We're in different parts of the system. And I guess we come at it from different ends. From my part, being general practice, I tend to see people in the early part and also see them, I suppose, when they're less differentiated. So next slide, please. So I think the important thing to say is that this is one of the personality disorders. It's one of the more dramatic ones. And I thought I would just do a quick definition about what a personality disorder is. So it is generally a pervasive and enduring way that someone thinks, feels or behaves. And generally the behaviour or particularly the behaviour does deviate from what is expected of the culture. And to get classified as a disorder, it usually has to cause significant distress or problems in functioning. And I suppose that's slightly different from a personality trait. So a personality trait may have some of the features, but not necessarily all of the features. And the person's functioning may certainly be better. Next slide, thanks. So look, I apologise for how quickly we're going, but there's a lot of slides to get through, and we might just try and shoot through them and then have time for questions later. So I thought I'd talk about a self-disorder because a borderline personality disorder is fundamentally a self-disorder. It's taken me a long while to sort of think about what constitutes the self and how a disorder does affect someone. But basically what happens is that, your sense of who you are develops in your early childhood, and it needs some other person to help you develop that. And usually through that developmental process, if it's not consistent, or there's some trauma in that, there results in confusion or lack of sameness in that person's inner world. And so the self is thought as, if you're undergoing experience, it's the I that's undergoing that experience. And also it's the I that's separate from the next person or separate from you. And interestingly, if you do ask a lot of people with borderline personality disorder, do you know who you are? Quite often they'll say no to that. It's a very non-specific question, but pardon me, if they do say no, it is an indication that perhaps they do have a self-disorder. So next, please. It has several consequences, though. The inconsistency, the internal inconsistency, affects how they function. And if the internal I, or who they think they are, is dependent on the experience they're having, then who they see themselves as fluctuates depending on what's happening around them. And that really can be quite distressing. And so usually you see these people seek some form of attachment. And this attachment helps them create a more stable inner self. Unfortunately, it's not always helpful because the attachments are often dysfunctional, and the attachment could include to things like substances. You also see boundary confusion, so they don't really know when they should step in and when they should step out. Often they over-identify, and certainly under-responsibility is something that we see in their lives. And the other difficult thing is that they have difficulty initiating and completing. Their drive it varies depending on what's happening. Sometimes it's there and sometimes it's not there. And they do have trouble starting. And sadly, they also have unstable self-worth. So who they think they are, or how well they think of themselves, fluctuates on a day-to-day basis. Next, please. So it manifests itself in three broad areas: emotional difficulties, and from general practice point of view, what we see is people presenting with behaviour difficulties and relationship difficulties. Next, please. Okay, so I might hand the diagnostic criteria over to Nick.
Thank you, Mark. Hi, everyone. A little bit of the dry stuff to start off with, but I think it's important to understand the criteria. You need, for the diagnosis, you need 5 out of the following 9 criteria. And I use the mnemonic suicide, which you'll see on the left-hand side as we go down the criteria, to remind me what it is that I need to ask about. The abandonment sensitivity is important. We all struggle with abandonment from people who are significant to us. If my wife goes out tomorrow night and I'm expecting to have a nice night with her at home, I'm likely to be disappointed or something like that. That's abandonment difficulties or sensitivity. But for my patients, that's a catastrophic experience where they might want to die. They might, take the keys from the car. They might, even one of my patients let her partner's tires down so that he wouldn't go out. So it's an exquisite sensitivity to abandonment, real or perceived. The second one, and probably the cardinal thing that is most at the heart of all of this, is mood instability. These clients, these patients, their moods go up and down from moment to moment, hour to hour, very rapidly and frighteningly deliberately for them. Their moods are their moods are often powerful, but something that creates an internal sense of confusion, rather than using their emotions to kind of figure out their way through the world like the rest of us hopefully do. For them, moods are powerful and capricious, and are like a overwhelmingly hostile sea that throws them around and destroys their life. Suicidality, chronic suicidality is another cardinal criteria. These folks usually have felt suicidal all of their life, maybe with a little bit of on and off, but this is not people who have had a bit of suicidality. They've usually felt suicidal from early teen years, and many of my patients will say they've been suicidal since they were young kids, since the first time they had kind of consciousness of those ideas, 8, 9, 10, 6, 7 even. The other bit of this criteria is deliberate self-harm, deliberately hurting yourself to create pain, or deliberately overdosing to try and get time out, or even to kill yourself. So these two things are separate, but either one, when they're ticked, are part of the criteria. They have unstable or intense relationships, usually with people that matter. Either the relationships tend to be up and down, or they tend to be overly invested in the relationship, so they become very intense. There's impulsivity in 2 or more of 5 areas. So the idea here is not just that the areas are a problem, but that there is a pattern of impulsivity. So are they impulsive with drugs and alcohol? So people who are dependent, this is not really what we're talking about. We're talking about impulsive and ill-advised use, or impulsive with sex, or impulsive with food, binge eating, impulsive with spending or gambling, impulsive with doing dangerous stuff like walking across parks at night when it's not a good idea to do it, driving cars way too fast, jumping off things to see how high it is. You can jump off something before you get hurt. But you need at least 2 to get the criteria. Next slide, please. The other criteria are that number 6 is the difficulty with controlling anger. The patient knows that their anger is at times out of control, or if it isn't out of control, if it isn't manifesting externally as anger out of control, it feels like a volcano inside, and they're terrified of it getting out of control. Identity disturbance, as Mark touched on from the self-disorder stuff, and that cardinal question, do you know who you are? If you ask that of most folks who have a sense of self, they don't really know what that question is. It doesn't really make sense. And mostly you'll get back, I don't really understand the question. What do you mean? Are you talking about where I work? Are you talking about who I am? Because when you've got a functioning sense of self, you don't need to worry about it. However, for my patients, when I ask them, do you know who you are? They almost always say no, and they know exactly what I'm talking about. And it's often the answer is with a great deal of pain. Dissociation is a huge and important area. These patients have, there's a continuum. Some of my patients have a lot of dissociation, and in fact are probably more in the dissociative identity disorder area, right up that end, the very extreme end of dissociation. Some of them have minimal dissociation, but so there's a range. And dissociation consists of roughly the following experiences: either feeling unreal within yourself, that's called derealization, or that everything around you on the outside is unreal, that's called, sorry, the other way around. The unrealness inside is depersonalization, and the unrealness outside is derealization. But it doesn't matter. They have a horrible feeling that either within themselves or outside of themselves, things aren't real, they're strange, people are like robots, etc. They also have auditory hallucinations, which is a real problem for psychosis. We used to think that people with auditory hallucinations had psychosis exclusively. Now we know that this is a common experience in borderline personality disorder and is thought to be a dissociative experience. They have gaps in memory, amnestic episodes or amnesia, and these are not usual memory problems. I couldn't probably tell you what I had for dinner 4 nights ago, but I would be able to tell you what I did today roughly, whereas my patients might have, for example, a gap of 4 or 5 hours where they have no idea what happened. one of my patients said a couple of days ago that he was, his girlfriend had charged her phone. It was on 1% when she put it on. And then a minute later, it was on 70%. And he said, there's something wrong with your battery. And she said, no, it's been 3 hours that it's been on. And he had no memory whatsoever of that 3 hours. And then at its most extreme, multiple identities. The last criteria goes with the identity disturbance, and this is emptiness. When feelings, the way we know who we are and the way we feel like there's something substantive within us is that we key into our emotional experience. You'll have to trust me on this. That's a whole talk in itself. And when that's missing, when emotions inside are confusing and capricious, then not only do you not know who you are, but also you feel like there's nothing inside. So they have an experience of emptiness or pervasive boredom that is there all the time and has been there all their life. Next slide, please. So let's talk about etiology. It used to be thought that the etiology of borderline personality disorder, the causation, was childhood sexual abuse. And then we realized that although these patients are way overrepresented with childhood sexual abuse, it can't account for all of the patients. Probably around about 50% at maximum of our patients have childhood sexual abuse. So then they added violence, witnessing domestic violence, growing up with violence outside or inside the home. And again, although they are overrepresented here, it still doesn't account for all the folks with borderline personality disorder. Now, what's known and what is the best predictor of borderline personality disorder is attachment trauma. This is not sexual abuse, violence, domestic violence. This is your caregiver hurts you as well as looks after you. And there's an unbearable experience for the developing, particularly the developing very young child, where the main caregiver is both the person that lets them down and hurt as looks after them. And the child doesn't know how to manage that. Now, Mark has added a question here. What's the difference between borderline personality disorder and complex PTSD? Borderline personality disorder is often seen pejoratively. It's often seen as a bad term. And that particularly came out of prior to the early 90s when we didn't have any treatments. So people generally felt hopeless and helpless with borderline personality disorder. Nothing would change. Mental health clinicians tended to look down or be exclusionary of patients with borderline personality disorder. That's changing now with effective treatments. It becomes a more useful diagnosis. Complex PTSD was developed by a woman in the States called Judith Herman. In response to that, she wanted to have a less pejorative label, and have about 50% of our borderline patients do have PTSD type symptoms, but about 50% don't. So I don't like it as a term, but I'm aware that many of my patients do. So I'm willing to cop that, but it's not an official diagnosis. And it has some problems. All right, next slide, please. So I won't spend too much time on this. I think this is an important area, and it helps you to understand why the patient with borderline personality disorder has the problem. And I'll give you a very quick example. I had a patient who, she was seeing me, and she was the mother of a 3-year-old little girl. And the 3-year-old little girl came with the mother to the session and stayed downstairs in the waiting room with my patient's mother, with the little girl's grandmother. When they left, I went out on my balcony. I have a little balcony outside my office, and I watched, and I just happened to see my patient and her 3-year-old daughter walking down the road. I don't know where the grandmother was. I think she might have gone off somewhere. And they were about 20 meters away, and the little girl was running down the street on the pavement, and she fell over and skinned her knee. I couldn't see the mother's face, but I could see the child's face. I could see the back of the mother's head, and the child froze. It's not normal to freeze. What the child should do in a healthy attachment relationship is the child should cry, put their arms out, want comfort from mum, but this child froze. And the reason she probably froze was because she's experienced thousands of experiences where she's been upset or in trouble, and mum has either frozen or become angry, or both. And that's a disastrous thing for a kid. So that little girl, that 3-year-old, then learns to avoid displaying any emotion because it's dangerous in the context of her caregiver. And she learns ways of dealing with painful feelings that are compensatory but ultimately maladaptive. She'll learn, usually by the age of 6 or 7, how to hurt herself in less sophisticated ways and more sophisticated ways once she gets to 13, 14. That's a way of dealing with painful emotions. Or she'll act out impulsively, or she'll dissociate, she'll disconnect, she'll go somewhere else. So I'm trying to show that the criteria I went through are really byproducts of this fundamental difficulty. When these compensatory behaviors don't work, there's breakthrough experiences, there's the mood instability, there's trying to cling on to relationships, which makes them intense and unstable. When it all doesn't work, there's the wish to die, there's explosions of anger, and there's further dissociation. And as a consequence of emotions being avoided within and without, there's this loss of an emotional self. And as a consequence, as I explained before, leads to emptiness, a sense of not knowing who you are, and abandonment sensitivity. Next slide, please. Mark, could you talk to this, please?
So this is one of my patients who is probably one of the worst borderlines I've seen. I've looked after her for many years. But this was part of her story as a child. So I'll just read that out. You know, she says that her father was a con man in many ways. He had lots of schemes going on, not all of them truthful, but he expected her to do his bidding and cooperate in the many charades that he organised. He spent money on appearances and influenced people by making them believe that he was well off. He used different names a lot of the time. He would go on expensive holidays, but flee before the holiday ended so he didn't have to pay. He had a number of companies that went bust. And even though he was an angry man, she preferred him to her mother because at least you knew where you stood with him. She's learnt that there's always an agenda with her father, and she constantly questions her agenda as well as other people's agendas. So that sort of really inconsistent attachment is very damaging. So she really had a difficulty knowing who she was, and who she was basically fluctuated on a daily basis. So next slide, please. So Nick.
Okay, so let me just go through the functions of deliberate self-harm. Whenever I talk to emergency department clinicians, and I'm doing another talk, I think it's next Tuesday, to a bunch of emergency department clinicians, and I ask them, why do people hurt themselves? They always answer in order to get attention. That's a medical myth. It's a very pervasive medical myth. It's a very strong medical myth. Klonsky did a review of 7 functions of self-harm and found that the greatest support for the function was affect regulation. In other words, self-harm, and in about 75 to 90% of respondents, and there are a number of different studies like this, will say the main reason they do it, it's not the only reason, but the main reason they hurt themselves is to bring down unbearable feelings like unbearable self-hatred, unbearable shame, unbearable anger, unbearable fear, unbearable sadness. That's what they use it for most of the time. We did a study in Newcastle where we asked 60-odd patients, actually 72 patients, and we gave them 21 different reasons that we'd heard of for deliberate self-harm, and around about 85% of them said the number one reason was to bring down painful feelings. Interestingly, out of those 22, number 20 was to draw attention to themselves. So it does happen, it's true, but it's actually one of the least common reasons and most least used. The affect regulation function is replicated in lab experiments. There's also some evidence for self-harm as a self-punishment. These patients hate themselves, and it feels somehow matching and appropriate to punish yourself for being a bad person. So that's one of the other reasons. And then there was less evidence as a way of terminating dissociation. When you're zoning out, when everything feels unreal, you cut yourself, you can bring yourself back into reality. And the other one that I find is quite important, although it was number 4 in the Klonsky study, was that patients will say, I hurt myself because at that moment I really want to kill myself, and it's the better of two evils. Next slide, please. So what is the stats around suicide in borderline personality disorder? And this is quite important. The overall suicide rate is in untreated cohorts is about 10%. So it's as high as it is in major depression, anorexia, bipolar disorder, psychosis, all similar, all hover around 10%. But what's different in borderline personality disorder is that usually they don't kill themselves when they're young. They're more likely to use deliberate self-harm in their teens and their early 20s, including attempted suicide. But actually completed suicide is relatively rare until they're in their 30s. If you want to check this up, look at Joel Paris's excellent article in 2002 on this. In their 40s, however, what happens is the urge to die and the deliberate self-harm actions tends to go down. As they get older, from their 40s to 60s, they tend to try to kill themselves less and try and hurt themselves less. They still do it, and I get asked for consultation in psychogeriatrics with patients in their 60s, late 60s, 70s, and 80s who still try to kill themselves, but it's rare in borderline personality disorder. It usually fosters in other ways. However, it's not just the 10% suicide, but there's also an increased death rate. So in the longest prospective study showed that there actually was, which ran over 27 years, there was an 18% death rate. So there is reduced longevity. Next slide, please. And Mark, could you talk to this slide, please?
Yes, so there's, I just thought what I'd do is go through my notes on the patients that I've seen and just bring out some excerpts from them. So this relates to that girl who had that history with the father. And, you know, this is the type of suicidal ideation that she gets. She came in quite distressed. The distress had been worse in the last couple of months and been precipitated by a number of stressors. So generally had traditionally been a bad time for her because it's just after Christmas, and that amplified her sense of being a failure if the children weren't happy. And her birthday was actually on January the 1st, and each January she had this recurrent disappointment that she hadn't died. And she wanted to die, but she was ambivalent about dying because her children were her concern as well. This is another patient. Self-harm started at the age of 14 when she took a packet of Panadol. She self-harmed since the age of 15, usually through cutting her arms. It was a period without self-harm, but he had started again recently by cutting herself on the legs. And these are her thoughts. I think it only helps temporarily. She has thoughts of not wanting to be around, and that's been coming and going since the age of 15, but more persistent recently. Next slide, please. This is the first patient again that we talked about. We discussed a number of issues, including her need for validation via keeping other people happy. She's sensitive to criticism and has a range of behaviours aimed at reducing her guilt if other people show their displeasure towards her. And she continues to test her relationships as she finds not knowing more distressing than being told the truth. So she was always testing to work out whether you were going to abandon her or not. And you know, she preferred that to know that. And it was a great distress for her because she never really knew whether she was accepted or whether she would be abandoned at any moment. And lots of her efforts went towards finding that out. Next slide. So this is the same patient again. She stayed away from her children for fear of damaging them, yet any positive involvement from others caused her to disparage herself for failing as a mother previously. She acknowledged that she fluctuates from periods where she's coping to other times where she's quite down and thinking about dying. So her mood was really all over the place. And the more she hated herself, the more she distanced herself from the children so as not to have a negative impact on them. This is a different patient. Sometimes I'm on top of the world, then I crash. I can go from good to bad in one day. And my whole life can crash down from one thing. It turns to shit. I don't want to be here. And I think, this is the feature, I think, of affective instability. So sometimes people come and say, look, my depression's terrible. But when you actually take a history of the mood, you find that they do have really terrible periods, but they also have good periods of the day, periods when they get extremely angry as well. And so really affective instability is more like 4 seasons in a day. Depression is more like winter, persistent winter every day for several days. Next slide, please. This is the same patient again. Alternatively, she thinks, what is this about? It's usually an event that has happened in the past, and it causes her to question whether she is a good mother and whether she has the right to do what she's planning. If her children were having difficulties, then it was due to bad parenting. Alternatively, if they were upset, then it was due to some failure on her part. So very much how she felt about herself depended on whether other people were happy or not. So externally validated. Next slide, please. So Nick, over to you.
So there are problems with assessment, and one of the big problems is that their priorities are often different to our priorities. When I talk to mental health clinicians and a patient with borderline personality disorder comes in who's self-harming, the first thing the clinician wants to do is to try and help them stop self-harming, or if they're feeling suicidal, to help them to stay alive. But that's not necessarily what their priority is. This may be the best and only way that they know to survive unbearable feelings. So their priority might be to keep the self-harm, or their priority, as Mark said before with one of those excerpts, might be to be dead. That's what's important. So there's a problem here where we have different priorities. The other problem we have is that the patients almost always don't trust us. They don't trust their parents because their parents usually have not been emotionally trustworthy. They don't trust their partners. They don't trust previous treatment. And most importantly, they don't trust me and they don't trust you. Often they'll look like they trust you and they'll say things about trusting you, but fundamentally, when all of your life caregivers have been untrustworthy, have let you down, have hurt you, then that's what you're going to expect at some deep level. So there'll be intense anger and devaluation that can occur when that actually happens. When we do let them down, even inadvertently, you might be too busy that day because of a crisis to see the patient with borderline personality disorder that's come to see you. Or you might get sick, or you might go on holidays at a time they really need you. And then you may experience some of this anger or this devaluation. Alternatively, when you do show up for them and you do provide care and it's different to what they expect, they may idealize you. They may excessively idealize you, which can be extremely uncomfortable. The patient that says to me, you're the first doctor or the first clinician I've seen that actually understands those previous 12 bastards all have been a waste of time, but finally I found the right person. And you kind of know, or I kind of know, and I get worried that the next time I disappoint them, I'll join that list of 12 and it'll be a list of 13. Next slide, please. There are problems with comorbidity, and some of it really isn't comorbidity. It's really just part of the whole package of what it's like to deal with attachment trauma throughout your life. Depression is not completely ubiquitous, but extremely common. So around about 80% will report major depressive episodes. Bipolar disorder is not that common as a true comorbidity, but there's often mistaken diagnosis, and Mark will talk to this a little bit later. Often there's a confusion around psychosis because they do have often about 30 to 50% have auditory hallucinations and 30 to 50% become quite paranoid. So it's easy to misdiagnose them with schizophrenia. Drug and alcohol is commonly occurring, dependency sometimes, even more importantly, even more commonly, misuse, abuse of drugs and alcohol. Although I talked with a drug and alcohol psychiatrist yesterday, and he was saying it's amazing how often when the dependence issues are dealt with, what's underneath is personality difficulties. Eating disorders are very common, particularly binge eating disorder and bulimia, less common anorexia. Anxiety disorder is extremely common, 85%, and as I mentioned before, about 50% will have criteria for PTSD. Dissociative identity disorder, I think, is extreme form of dissociation and is often part of this. And often there are other personality disorders. Some of our borderline personality disorders are extremely narcissistic, some are antisocial, etc. Next slide, please. Mark, could you talk to this slide, please?
Yeah, so it's a common difficulty, I think, when someone does have fluctuating moods, and particularly when there are periods when the mood is quite elevated, and usually these people come along and they have struggled, they really have struggled, and they are looking for a solution. But I think it's really important to know whether it is bipolar or not, because it really has huge implications for management. If it is bipolar, then mood stabilizers and medications play a much greater role in the management. But if it's not bipolar, then really psychotherapeutic options are the best. And I don't think you really do patients any favors if they have a bipolar diagnosis that really isn't, because they can get stuck on these medications for a long time before someone twigs and starts to address the personality issues. So there is pressure though for the diagnosis of bipolar, because it means that the responsibility of managing is placed on the treating team, and it's the effectiveness of the medications that's required there. And I also think bipolar has less of a stigma than, say, something like borderline. But so I think it's important to really work out whether they do have an episode of mania or not. And unlike affective instability, which is usually short-lived, the mood elevation can be hours, maybe a day or two. It's usually not. It usually doesn't last for a week. And so the diagnosis of mania needs elevated mood for at least a week and present for most days. And associated with that is the other aspects of mania. So irritability, goal-driven, expansive, grandiose behavior as well. So the other feature is that the mood symptoms are in a borderline are often triggered by current events. So if there's a more direct relationship between the mood and a current event, then it's probably less likely to be bipolar. Next slide, please. So Nick, could you speak on this?
Borderline personality disorder. Really, the question is, how can I help you? But the order below that I'm going to outline may be crucial, particularly the first item. Going into your usual medical evaluation or your psychiatric evaluation can be very off-putting for these patients, and in fact can lead to problem, either the patient blowing up or shutting down, neither of which is helpful. So the key point here is that whatever you ask, it needs to be done in an empathic way, and it needs to be centered around their emotional experience. because that's what was ignored or wasn't appreciated or wasn't asked about when they were kids. So this is going to be a flashpoint if you ignore their often very intense emotional experience. So we want to try and find out about how they feel a fair bit before we go into data collection. And otherwise, the data collection is experienced as persecutory. It's experienced like you're a dispassionate reporter or judge or someone who's taking information, and that can be very triggering for them. Once you've done that, once you've established how they feel and what it is they're here to talk about, then you need to establish the diagnosis. So you do need to know about those criteria. It's good to know about deliberate self-harm and ask directly and openly about it, also drug use. Of course, it's important to assess safety and to differentiate between, is this a problem of acute suicidality? Is this something that's very recent, or is this something that they've experienced most of their life? Have they had past suicide attempts? Because past behaviour is the best predictor of what might happen in the near future, and hospital admissions. Treatments need to be asked about past and present, because if you're going to recommend anything, you don't want to be recommending things they've tried and haven't worked. That's very frustrating for patients, and I hear that quite often. So you want to know about what kind of psychotherapy they've had, medications, etc. Next slide, please. You also want to know a little bit about what resources they have. How do they manage crises? What kind of internal psychological resources do they have? Because again, if you get into a crisis with them, it's nice to know what has worked in the past and what they can use. Similarly with social resources, it's nice to know who in their family and friends or partner is there for them when they're in a crisis. What are their professional resources? Are they having psychotherapy? Do they have a regular psychotherapist or counsellor? Are they seeing a psychiatrist? Do they have regular contact or previous contact with the mental health team? Because all of these things are going to be needed if they get into a crisis, and you have to manage that. The other important thing I often don't do well is make sure that I've got accurate contact details, so that if there is a crisis, I can contact them, or I can give a mental health team information about how to contact them and how to follow up with them, how to not just contact with them, but what's their preferred way of being contacted or following up. And of course, very important is, what do they want? And underneath that, what stage of change are they? Are they wanting a little bit of symptom relief? Are they wanting to change their life and really get better? That is a very important assessment, because if they just want symptom relief, sending them off to psychotherapy, which is a more definitive treatment, isn't going to work. If, on the other hand, they want to really address this and change their life, symptom relief is going to be frustrating for them. It's not enough. Next slide, please. Mark, your slide.
Yeah, so this is my take on assessing them in PEC. You know, sometimes it does feel like the octagon, and there are certain behaviours that they can display, and that makes it difficult to manage. But you have to be aware of that, you know. So one of them is splitting. So what that is a tendency to idealise or to value, and I think Nick spoke of that before. Like, you know, if someone comes along and says, you know, no one's understood me, that's it's just a marker that you have to be a little bit wary and not take that at face value. The other difficulty too, particularly in a general practice, is that different members of the team can be assigned different roles, if you like. So you might find that they think, you know, really highly of a particular doctor, but by the same token, they think really poorly of your nurse, and that can cause difficulties within the team as well. So just have to be careful of that. So projection. So that's when strong feelings that they have, that they have difficulty recognizing, they attribute to you. So you often hear, you know, that doctor was angry, or that, you know, that doctor was mean, or he didn't listen to me. And projective identification is one more step in that, and that is those unrecognized feelings attributed to others. However, once those feelings are attributed to the other person, they then encourage to act those feelings out. So if for instance they are unable to recognize their own frustration, you might suddenly feel increasingly frustrated in the consultation because they are not getting better, or you're unable to help them, or there's a degree of help rejection. Next slide. So there's a degree of this emotional grappling that goes on. You just have to be a little bit aware of that. So transference is that when the patient directs their feelings towards the therapist, and those feelings belong to some other significant other in their life. So they might see you as a very paternal character, for instance. And again, you have to be careful responding to that. So countertransference is the important thing, I think, for GPs. Really, you have to be aware about what your own feelings are, because they might be based on some of your experiences and not necessarily related to this current consultation, just simply because the client reminds you of an experience that you've had in the past. Next slide, please. So there is a slightly different language. They don't ask and they don't receive in typical ways. So I think what you're trying to do is manage that difficulty in that language. So stay warm, stay steady, be curious. What that tends to do is it sets the conditions of the consultation, if you like. So without conditions being relatively calm, it's actually hard to get to the content. Also, you need to be able to tolerate their distress and also your discomfort if they are displaying strong emotions. And even though they might present with a somatic symptom, or they might present with a direct request, I often have to ask myself, look, what is it that they're actually asking for? So sometimes they have difficulty asking because, the lack of validation in the past. They don't expect people to hear what they're saying. So in a way, they act out a behaviour to try and engender the result that they want. So sometimes they just simply need containment. So particularly in the admission unit, there's someone who's extremely distressed and has very little support in the community, and isn't really able to enact any safety plan for themselves. Then admission, short-term admission, might be what's required. A lot of the time, though, it is actually about someone trying to understand where they're at. One of the difficulties is that they do tend to come in to ED after they've exhausted all their efforts, they've exhausted all their resources, and nothing just seems to be working. And that doesn't necessarily need admission, but with support and a plan that they can actually engage with, they might be able to go home and pick things up from there. And the other difficulty is also control. So these people often don't have control over issues in their life, and the control can be over things like finances, control over things that are happening around them, just difficulty accessing the community, and again, support and some enhancement of their ability to enable themselves is probably, if they're receptive to that, they can go home with that. Again, speaking to the trust issue, I think, I generally think it's a good idea to underpromise, but if you do, then deliver. And that really does help build trust over time. And be prepared to repeat this over and over again. In my opinion, if regular appointments do help avoid the crisis presentation. So generally what I will do with my own patients is set an interval period and reassure them that I will see them. And to some extent that helps them because they're so unsure about where they will be from one day to another. Setting an appointment acts a little bit like a ladder into the future for them, and surprisingly they do hang on to that, and they will turn up. And also caring for these patients, you have to maintain your psychological core. So you do have to hear them and so forth, but when it comes to your own practice, you need to practice according to your own goals and values, and to have your boundaries where they need to be. It's not a good idea to be stepping outside your usual practice, to be over involved or doing things you wouldn't normally do. That creates problems later on. Next slide, please. So look, what to do. So this is what I do when I see them in ED. And I use an analogy, and the analogy really is a sailing. So I say to them, look, if your boat is being blown off course and it's a very strong breeze and you don't know what to do, I say the first thing you do is you don't jump off your boat, So I address the suicidality, like how seriously are they entertaining this concept? And, if they are entertaining this concept, then you have to contain them. However, you can sometimes talk them and they can see this. They can, I say, look, the first thing you do is you try and stay on the boat. And if they can accept that, then I move on to the next step. The next step really is to avoid sabotaging behaviours, because I say to them, look, if you're on the boat, then don't smash the boat because it's not working, and don't lie down and let go of the sail and the rudder, So that's acting out behaviour. So we really want to minimise the acting out behaviour, and we also want to minimise behaviours that are going to interfere with ongoing outpatient assessment and treatment. So substance use, compliance with medications, appointments, and so forth. If they can do that, then I move on to the next step and I say, look, even before you learn to sail your boat, what you need to do is learn how to maintain your boat and keep it in good order. So I ask them to get a regular sleep pattern and to have a daily routine, to incorporate some exercise, watch their diet, and have a better day-night pattern. Now, I may use some medications if it's appropriate. And the last bit I say is, look, once you've got all of that in place, then maybe you're ready to have some lessons in terms of working out how to sail your boat and make sure it actually goes where you want to go. And that's probably where Nick steps in more. Next slide, please. So Nick, I'll get you to talk to this one.
Okay. This is really just a summary slide of treatments. Let's go on to the next slide, please. So let me talk to medications first and some general issues briefly. We're going to run out of time, so I'm going to be fairly quick with this. The first thing to remember is that for the usual things that medications work for, like depression, anxiety, psychosis, voices, auditory hallucinations, etc., in borderline personality disorder, these medications generally don't work. They don't change the trajectory. They're not a cure. They may be helpful, often modest help at best, for some symptom relief, but that's the best you can ask for. Don't forget that when you have a do prescribed to the patient with borderline personality disorder, it feels like care to them. So it may not be the chemical that's so important or the physiological response. It may be the act of prescription and showing that you care about them. So the placebo response is important in these patients. Be aware that these patients suffer terribly. The medications don't work very well, if at all. So they're going to come back to you and say, I still feel bad. So don't go symptom chasing. Don't load up medication after medication after medication. Zanarini in the States did a study of 360 patients with borderline personality disorder and found that they average 4.2 psychiatric medications per patient. That's nuts. The other problem is that occasionally these patients who are in great distress, with people in great distress, will misuse the medication. They might use it for overdosing, they might use it in weird and strange ways. Because the medications don't work very well, compliance doesn't mean much. I don't get too upset when the patients don't comply with medication. If they say it's not working, I trust that because usually they're right. Which means that collaborative prescribing is better than unilateral prescribing. It's a bit different to how I'd prescribe with someone with schizophrenia, where I really make a decision about what I think is going to work. In this case, I really work with them because I know nothing's going to work that well and I want to try and get them on board. However, there are some psychiatric medications I'm reluctant to use because they're just too toxic. Tricyclic antidepressants, lithium, they're the two medications that people can really hurt themselves quickly when they overdose or misuse. So unless I've got a very clear history of not taking overdoses, I won't use those. Benzodiazepines, I'm also a bit reluctant, not for dependence, but because they're disinhibiting. They make people not feel frightened, and people who are chronically suicidal, I don't want them to be artificially brave with benzodiazepines. It's easier for them to kill themselves. And don't unilaterally stop psychiatric medications. Because you've heard me pour cold water on medications doesn't mean you then go in and suddenly stop them, because then that idea of caring about them suddenly gets shattered and they feel uncared about and unhelped, and that can lead to a crisis. Next slide, please. And the biggest problem with medication is, in the long run, they don't learn how to manage their lives better. They don't learn new behavior that they need to learn. Next slide, please. Some specific things. Here's the dampeners. The SSRIs and the tricyclics, the antidepressants, don't work for borderline personality disorder depression. Usually you expect a 60 to 70% response rate in major depression. In borderline personality disorder, you're getting a 10 to 20% response rate. It's pretty piss poor. Mood stabilizers don't stabilize their mood. Antipsychotics don't stop the dissociative voices or the paranoia. And benzodiazepines don't stop the anxiety. The best evidence is for short-term symptom relief, some modest symptom relief with sedating antipsychotics. Things like very small doses of olanzapine or quetiapine. Olanzapine usually 1.25 milligrams up to 5 milligrams a day. Quetiapine, we're looking at 12.5 milligrams up to usually a maximum of 100 or 200. I wouldn't ever really go over those kind of doses unless I had a bloody good reason. Lamotrigine has a little bit of evidence in some initial studies. A bigger later study has shown not much help. So it's a bit of an open question at the moment. But there isn't any of these medications aren't going to change the trajectory. So that's not the fundamental treatment. Next slide, please. Also, things that don't change the trajectory of the illness, supportive counselling. Being a good, nice, competent counsellor doesn't work. Cognitive behavioural therapy, CBT, doesn't work. Family therapy, couples therapy doesn't work. Social support, vocational support, accommodation support, none of these things, when they've been tested as an intervention, have shown any real benefit. Again, I'm not saying that these things can't be helpful for individual patients. They can, but they're not the treatment. They're adjuncts at best. Next slide, please. What about the psychiatric system? We have a similar problem here. The evidence is not good for mental health team interventions. Again, I think there is a place for mental health teams, but it doesn't change the trajectory. They're not going to get the patients better. They're there to help with crises. They're there to help you as a GP share the risk when you've got a chronically suicidal or an increasingly suicidal patient. They're there often to support psychotherapy when the patient crashes and burns and gets into a crisis. What about the private psychiatrist? Again, may be useful, but not necessarily. If the private psychiatrist is mainly wanting to use medication, then they're going to have a limited benefit. Again, there is a role, but it's not going to usually change the trajectory. Hospital admission, again, no evidence that hospital admissions, regular hospital admissions, make patients better. On the contrary, there is actually some disturbing evidence that the more hospital admissions the patients have, the longer and more frequent, the more likely they are to do poorly. So I use hospital admission as a last resort. The treatment, the getting better, is going to happen in the community, not in a hospital. But when all their resources are exhausted, as Mark said before, hospital can be, as a last resort, a lifesaver. ECT, I often get asked about. Absolutely no evidence for the depression in borderline personality disorder responding to ECT. I have seen a lot of patients with borderline personality disorder have ECT, and I can honestly say 2 out of that lot of patients got some short-term benefit. So it's not really the go-to. Next slide, please. What about the usual psychotherapies? Well, again, this is a bit of a depressing story, because up until the 90s, we tried all of these things. CBT doesn't work. The usual psychodynamic or psychoanalytic therapies don't work. Couple or family therapy doesn't work, as I mentioned. And the treatments for PTSD, which are well validated in PTSD, in post-traumatic stress disorder, such as prolonged exposure, EMDR, imagery rescripting, all of these things that do work well in PTSD do not work well in borderline personality disorder. In fact, there's no evidence of their benefit, and which is one of the reasons why I don't like complex PTSD as a treatment, as a diagnosis, because that leads you to the idea that I should treat my PTSD, and the treatments that do that don't work in this situation. Next slide, please. What it does need, and there's good evidence for, is borderline personality disorder specific psychotherapy. Those conventional psychotherapies have to be modified. And when they're modified, they're actually surprisingly effective. And there are a bunch of treatments, bunch of psychotherapies, and they all require these common factors, that they're a minimum of at least once a week for at least a year, quite often longer than that. So it's intensive treatment, but it's worth it when they're ready to work. Whatever the psychotherapy, it needs to be emotion focused. The difficulties around emotions are at the core, at the heart of this disorder. The therapist needs to actively explore suicidal ideas and deliberate self-harm, not to avoid that. It needs to be talked about. It takes you to the most difficult and painful emotions. The therapist needs to be actively engaged and warm. They can't use therapeutic neutrality, which used to be, in the old days, the way that psychodynamic and psychoanalytic treatments were delivered. The treatment needs to be flexible and negotiated boundaries. As Mark said, it's very important not to do what you don't want to do. And that's true not only for GPs, but also for psychotherapists. However, at the same time, it's important not to be rigid. You have to negotiate with them. And these patients put a lot of pressure on you and me to change our practice because they have such terrifically intense needs. And it's important to be aware of those needs, to respond to those needs, but not necessarily to overextend yourself. You will get into trouble. And interestingly, and little known, I often get asked, so DBT is the treatment of choice? No. Each of the psychotherapies are equally efficacious. At the Centre for Psychotherapy, we use 3 different models: DBT, conversational model, which is an adapted psychodynamic model, and schema-focused therapy in a group format, and each of them are equally effective in controlled studies. Next slide, please. So very briefly, from the CBT camp, dialectical behaviour therapy, or DBT, was developed. From the psychodynamic camp in Newcastle and in Australia, you usually get conversational model and MBT, or mentalisation-based therapy. And then there are hybrid treatments, schema-focused therapy, which is a hybrid of CBT and psychodynamic. And when they're compared to each other, they do about the same. Next slide, please. But the biggest problem is that getting psychotherapy, and I'm sure all of you struggle with this, and I need to talk about it briefly because I'm going to get a lot of questions about it. The 10-session mental health plan is not treatment. it doesn't work. Doesn't matter how good the therapist is, doesn't matter what model they use, it's not going to change the trajectory. As I said, a minimum of once a week for a year has been shown in studies. Less than that doesn't really work. So if the patient can afford $100 or more per week, then there is a list of private providers, private mental health clinicians who can see them in the private system, and they need to be using probably a fairly specific or borderline personality disorder adapted treatment, or at least be aware or comfortable with working with these patients. And so I've got a list of local providers, and then there's a bigger list if they're going to use digital therapy, Zoom-based therapy. The problems with that with borderline personality disorder, however, sometimes better than nothing. For those, and the vast majority of the patients I see in the public system, they can't afford that kind of money. And then we just scrap around for what is available. The Centre for Psychotherapy here in Newcastle is an anomaly. There just aren't free, publicly based psychotherapy for these patients generally around. You do get some psychiatrists who are able to and trained as psychotherapists and are willing to treat them, or some GPs similarly trained as psychotherapists who can treat them and use the Medicare rebate. Some community mental health teams have a very small space for their psychologists to be able to see some of these patients. Sometimes the patients will get funding for therapy through the NDIS. They can sometimes get 22 or more sessions with vocal victims of crime, but it's really scratching around, and it's a real problem in our community. Next slide, please. Those, however, it's the treatment of choice is psychotherapy, but if the patient's not ready for psychotherapy, no point referring them off to something that they don't want to do and they're not ready for. Psychotherapy is hard work, and it often involves facing emotional pain. And until they're ready to do that, I don't want to set them up to fail and send them to something they're not going to do, or they're going to do half-assed and fail and then feel like a failure. So if they're not willing for psychotherapy, you have an important role as a GP, often for medication, often for crisis or support management, as does the mental health team. They may family education or family support services. We have a system called, we have a group called ARAFME in Newcastle, which provides support to family members of patients with mental illness. And really it's about providing them with that support until they find the reason to live, or the reason to engage, or the reason to want to change their life and engage in psychotherapy. Next slide, please. So what can you do, given that you're not going to provide this, a psychotherapy treatment? It doesn't, I'm also being a little bit contradictory here, but I think it's important. Every time any mental health clinician, including GPs, focus and understand the patient's emotional experience and responds to that in a way that is caring and with interest and tries to help them, that builds an emotional bond. That's a little brick in the wall. That's essentially what we do in psychotherapy over weeks and weeks and weeks, months and months and months. Of course, it's important for you to manage their medication and their physical health. Even if that's not the primary thing that's going to get them better, that may be the way that they can interact with you to develop that emotional bond, to help in crises, as I mentioned, and when they're ready to refer for BPD, adapted psychotherapy. Next slide, please. I'm aware that we're running out of time. I don't want to go through this slide, but yeah, so I'll go on to the next slide, please. And this is the last slide, I think. Let me just check my notes. Yeah, it is. Interestingly, up until 1992, we thought these patients were intractable and they never got better. Now we've got treatments. We know that's not true. The prognosis is surprisingly good. Even without intervention, also the long-term trajectory is kind of better than we thought, because as I said, self-harm and impulsiveness, self-destructive behavior gets less as people get older. We become less impulsive. All of us do, and so do the patients with borderline personality disorder. But without treatment, in their 40s, 50s, and 60s, they remain miserable, and they remain poorly functioning in terms of work and family. So in one way, you can't diagnose them with borderline personality disorder because some of those criteria change, but in the terms of their core experience, they're usually not doing very well. However, with treatment, there is a better outcome than with schizophrenia, than treated schizophrenia, treated bipolar disorder, treated anorexia, treated severe or chronic anxiety disorders. That last dot point is something that people don't, is a little known fact. These patients get better, and they get better, even though it takes a year, 2, 3 of psychotherapy, they get better surprisingly quickly, and usually more consistently than many of the other mental health disorders. That's all from me. Let me hand over to Sandra.
Well, thank you so much, Nick. That was really fantastic, Nick and Mark. I've been sitting here taking copious notes, and we'll be updating the health pathway tomorrow. And can I just remind you all, we've got this amazing resource in Nick and Mark here tonight. So please type your questions into Slido so we can ask them while we have them. So I'm just going to quickly show you around the health pathway. And before we go on the screen, you should be able to see the login details for both the Hunter New England site and the Central Coast site. On the left, we have Hunter New England, and on the right, Central Coast. And down the bottom, we've got the login details for patient info. So you only need a URL for the patient info site, and that's a site you can share with your patients and direct them to find reputable evidence-based information that where the recommendations are in line with the clinical recommendations of the pathway. So just moving on, so on the Central Coast site, we do have a deliberate self-harm pathway, but on the Hunter New England site, we have deliberate self-harm and borderline personality disorder. The borderline personality disorder is currently under review, so that will be being updated. And we wrote the deliberate self-harm one with Nick a couple of years ago, which was a fabulous experience. So as you all know, I hope, to find pathways on the pathway site, you can either search up the top here in the search bar, or you can go to the table of contents on the left. But if we put borderline personality disorder in there, that of course is the first thing that comes up. And this pathway is set out like all our pathways are. We've got the red flags at the top, a little bit of background about borderline personality disorder, and then assessment, management, and referral. And here in the referral, when you click on any of these links, you'll get through to the different referral pages. So for example, if you go onto the psychiatrist link, as all our referral pages are, they're set out by geographic area, and you go to the area that you're currently in. So for example, Newcastle. And then if you want to find a public service, you'll go down into the public service mental health services. And down under here, we've got, if referring for the Centre for Psychotherapy, which is where Nick is based, we've actually got the BPD referral form there that you can click on with all the fax numbers and things like that on it. Just moving back to this, and at the bottom of every health pathway, of course, we've got extra information for health professionals if you want to read a little bit more about it. And this, again, is evidence-based information that's hopefully current and always in line with what the content of the pathway is. And then down the bottom, we've got the for patients information. Now, all the information we put down there under for patients has been reviewed by our clinical editing team. It's also been reviewed by our patient information team to ensure that it's of a suitable readability level to be able to give to your patients so that they can read and digest and understand and make informed decisions from them. And usually it's a reading level of about grade 6. And I'll just, if you click up here in the blue bar, that'll get you back to the home page. And I'll just show you a little trick for getting onto patient info. Just here on the right-hand side, if you click on that, that will take you straight through the patient info site. And as I said, patients can get onto this without needing a password. But you can see here under mental health, we've got the borderline personality disorder resources exactly the same as what's on the health pathway. And we've also got deliberate self-harm resources here. So just moving back to the pathway, so deliberate self-harm, again, we have the pathway set out in exactly the same way: assessment, management and referral. And hopefully you'll find everything you need in here to help manage your patients, and down here to the referral section as well. And I think that is all from me currently. Charles, if you would like to go to questions, I'll just stop sharing. And happy to take any questions about the pathway if you'd like. When we're writing the pathways, we always use a development team, which will generally include a specialist like Nick, a GP like Mark, and whatever allied health relevant, and a clinical editor. And we all sit around, and the very first meeting we talk about what is and isn't working well, and what it is that we really want to hope to empower GPs with the pathway to make sure that it helps you work at the top of your scope and has all the resources that you need. All right, over to you, Charles or Mark or Nick.
Thanks for that, Sandra. Wonderful. So we do have some time for questions. So I might hand over to you, Mark, if you'd like to facilitate the Q&A.
Sure. Thanks, Charles. So there's a few questions here. The first one for you, Nick, perhaps. Patients who present with self-inflicted injuries, do they always have BPD?
Great question. The answer is no. In fact, you'll find that people with severe autism quite often have self-inflicted injuries, but coming usually from a very different place. However, if someone has chronic, as a pattern of self-inflicted injuries, deliberate self-harm, I think you're remiss not to ask about the other criteria. So the answer is no. There may be a bunch of reasons, but it's pretty likely that there's an important subsection that do have borderline personality disorder. So I think once you have a pattern of deliberate self-harm that is ongoing, then you really need to ascertain whether they have borderline personality disorder or not.
Great. Next question is, how long would you use low-dose antipsychotics for in terms of symptom relief?
The answer in terms of the guidelines is short term. So really the studies have been done for 6 weeks with the longest of 6 months. And the evidence is that, so that's where the studies have been done. There haven't been any studies longer than that. So the answer is we don't really know. My guess is this is part of the collaborative thing. I say to the patient, I'm not expecting that the low-dose antipsychotic is going to change everything around, but it might be helpful in certain ways. And usually it helps with sleep. If it's going to help at all, it's going to help with sleep. It's going to help with feeling a bit less angry or a bit less irritable. It may help with feeling a bit less anxious. Those are usually the domains that people report some improvement. And whether that works, I leave it as an open question. I say to them, like you to try it for a few weeks, see how you go. If it's helpful, come back and we'll discuss the pros and cons of continuing. And I, to some extent, leave it in their hands as much as possible.
Sure. Can you comment on differentiating from ADHD and comorbidity with ADHD, and what would make you suspect that this isn't actually an autism spectrum disorder and comorbidity with autism, especially with a trauma history?
That's a great question. I'm not sure that anybody has good answers to this, but I'll have a bit of a go. People with autism spectrum disorder don't get the rules of society. So I'm not an autism expert, but someone who works in this field said to me once, the idea of autism spectrum disorder is like the boy who's in the middle of who's in year 10 and he's in the middle of a school assembly where the whole school's there and the headmaster's talking and the headmaster has a stain on his tie. And so the kid gets up and says, look, it's got a stain on his tie. He doesn't get that that's a socially inappropriate thing to do. That's not the problem with borderline personality disorder. They're exquisitely aware of the rules. They may break the rules for a bunch of reasons, but they're exquisitely aware of them. So that for me is the difference. Do they understand what are the social bonds and ties and rules? If they don't, I'm starting to wonder about autistic spectrum disorder. If they do, then I think that it's more likely to be borderline personality disorder and therefore more a traumatic background. This gets trickier in girls. Girls are great mimickers who have, particularly those with Asperger's or mild autistic spectrum disorder. And so girls will tend to copy other girls, and therefore it's harder to tell, but they won't understand what it's about. They're just copying. With regards to ADHD, this is an area that I think is very difficult because trauma, particularly attachment trauma, but also more overt trauma like violence, domestic violence, childhood sexual abuse, etc., does lead to frontal lobe difficulties, which makes it difficult for them to manage and does lead to emotionality and things that are out of control. So I think it's a very common thing that borderline patients have trouble with attention, and some do with hyperactivity. But some of that is about trauma, and that will settle down when the psychotherapy addresses that. I have seen a few patients where actually stimulant medication did help. So they did have some kind of ADHD on top of that was probably more genetically based and more biologically rooted, and therefore more amenable to a biological solution. But this is a really fuzzy area.
Great, thanks. Will psychotherapy work in a patient with BPD and anorexia?
Another great question. Funnily enough, I've had this because I work at the Centre for Psychotherapy where we see patients with BPD and with eating disorders, some with both and some with one or the other. I mean, we see a lot with BPD and we see a lot with just eating disorder. When it's combined, it's usually more difficult work. And what we often find is that the patients are quite happy to work on the BPD, the self-harm, the chronic suicidality, but are much less likely to work on anorexia. It seems that anorexia is a more closely held survival strategy and associated with a great terror of weight and eating. And so in my experience, it's more often that you can work on the BPD, but not on the anorexia. And generally, I find that doesn't work very well. So when I have a patient with both and they say, I'm happy to work on self-harm, I'm happy to work, but I don't touch my restrictive anorexia, then I usually say you're not ready. It's a difficult situation, but that's often how it goes. With bulimia, bulimia and borderline personality disorder probably go together more, and they're probably both more an emotional dysregulation, being out of control with emotions, and the treatments seem to work better for both of them together.
Okay, so here's an interesting one, Nick. With a patient who enjoys body art and often does a lot of these themselves, for instance, tattoos, piercings, scarification, when can this be considered a love of body art versus intentional self-harm?
Yeah, this is another good question. I think the difference is what the function is. Scarification, body art, tattoos, when they're done for beauty, for self-enhancement, to provide that kind of function, then that's what they are. When they're done in order to stop painful feelings, then it's deliberate self-harm. And I've had a number of patients who have stopped self-harming, stopped cutting, but then when they were really in trouble, went and got a tattoo. And I treat that as self-harm. Not because I morally disagree with it, but because the function is trying to bring down or avoid painful feelings. And I want them to learn how to manage that through psychological techniques, not through hurting themselves.
Okay. So some patients with borderline can sometimes be attentive and good parents. However, when their children get older and leave home, can this cause a flare of their sense of abandonment and cause them to deteriorate?
Yeah, I don't know that I've got a lot of evidence around this stuff, and I don't have the long-term. Probably many of you as GPs might have a long-term, you'll see the families and you'll see how this plays out. I tend to have a more limited contact. I see the patient for a couple of years and then I don't necessarily get to see their lifelong trajectory. The evidence is that patients with mothers with borderline personality disorder or women with borderline personality disorder who become mothers have a very high rate of handing on borderline personality disorder or other difficult psychiatric problems to their children. And the only thing that seems to change that trajectory is psychotherapy. So there is one study that shows with mentalization-based therapy, a psychodynamic therapy developed in the UK, where they showed that the attachment difficulties really changed with the treatment, and they followed up the patients for a number of years, and the kids did not seem to have the emotional dysregulation that would imply they would go on to have borderline personality disorder. So treatment really does help with that. But I think the question is a good one. A patient who is managing her emotional or his emotional instability, but is somehow finding a way to be able to respond and not go down the attachment problems with the kids, pulling it together somehow. Various things, particularly abandonment experiences, might tip them into a symptomatic crisis.
Okay, so I think we've done pretty much all of them, but there's one here. What is the role for online self-directed therapies?
There's really no evidence in borderline personality disorder, I know, for self-directed therapies. And again, that doesn't mean that it's not useful. For our clients for the patients that we see here at the Centre for Psychotherapy and who are doing our DBT program, there are some online self-help apps that are good at supplementing the treatment. So I think there is a role for them, but given that the disorder is one of attachment, it's one of caregiving in close, intimate relationships, then I don't think we're ever going to find a treatment that doesn't involve some kind of manifestation of caregiving, that isn't at least delivered with caregiving. So I suspect that trying to do online treatment by itself will probably not work, but we just don't know the answer to that question. It hasn't been tested. There is sometimes in mental health teams, they deliver DBT skills without the DBT individual treatment. This is quite a common thing. Unfortunately, the evidence is not great for that. There isn't much evidence that DBT skills given either in a private hospital or a mental health team or a private practitioner without individual treatment works particularly well. So again, here I think this individual caregiving seems to be at the heart of treating patients with borderline personality disorder, at least if you want to change the trajectory.
Yeah. All right, so I think might be back over to you, Charles. That's the end of our questions here.
Wonderful. Thanks, Mark. Perfect timing. You've nailed it right on 8 o'clock. So thank you so much, everyone, for sending in your questions. That was great discussion. I want to take this opportunity to offer a big thank you to both Mark and Nick for generously giving your time tonight and preparing such an informative presentation. We really appreciate you coming online when you're all very, very busy at the moment. And as well, thanks so much, Sandra, for coming on and providing us with that really important Health Pathways update. Just a reminder, before you log off tonight, we would love it if you could fill out the evaluation survey on Slido. So you'll notice under the polls tab, it's sitting there waiting for you. If you could just fill that one out, we'd really appreciate it. As mentioned at the start, the recording and the slides will become available from tomorrow in our PHN education library on our website. So thanks again, everyone, for joining us, and we hope you have a great evening. Good night.